Today our topic is uterus. Uterus is a secondary sex organ. Secondary sex organs are the components of the reproductive tract that mature during the puberty under the influence of sex hormones produced from the primary sex organs, that is, the ovaries in females and testes in males. They are responsible for the maintenance and the transportation of the gametes. In this article, we should look at the composition and the clinical significance of the uterus and its vasculature, lymphatic supply and the innervation will be covered in this topic. This is the structure of uterus, which have the parts like fallopian tubes, ovary, uterus, cervix and vagina. So the T-shaped organ is called the uterus here. The anatomical structure is the uterus is a thick-walled muscular organ capable of expansion to accommodate a growing fetus. It is connected distally to the vagina and laterally to the uterine tubes. The uterus has three parts. One is fundus, the top of the uterus above the entry point of the uterine tube. Body is they have the usual site for the implantation of the blastocyst. Cervix, the lower part of the uterus linking it with the vagina. This part is structurally and functionally different to the rest of the uterus. Here they have cervix, body and fundus. This is the major parts of the uterus. The exact anatomical location of the uterus varies with the degree of distension of the bladder. In the normal adult uterus, it can be described as anteverted with respect to the vagina and anteflexed with respect to the cervix. Anteverted rotated forward towards the anterior surface of the body. Anteflexed flexed towards the anterior surface of the body. Thus, the uterus normally lies immediately posterior superior to the bladder and anterior to the rectum. Clinical relevance, that is abnormal positioning of the uterus. In some individuals, the uterus may not lie in the anteflexed and anteverted position. The three most common dispositions are excessively anteflexed, anteflexed and retroverted, retroflexed and retroverted. These abnormal arrangements do not inherently cause any medical problems. However, the retroverted uterus is positioned directly above the vagina. These instances of increased abdominal pressure, the uterus is more likely to prolapse into the vagina. Uterine prolapse. This is particularly prevalent in those with a history of pelvic floor damage. The normal position of the uterus will be in this way, which there will be a gap between the vagina and uterus. If there is anteverted, it comes very forward to the vagina. If it is a retroverted, the uterus will be on the upside. If it is a retroflexed, they will turn aside. Histological structure is the fundus and the body of the uterus are composed of three tissue layers. One is peritoneum, a double-layered membrane continuous with the abdominal peritoneum, also known as the perimetrium. Myometrium, the thick smooth muscle layer. Cells of this layer undergo hypertrophy and hyperplasia during the pregnancy in preparation to expel the fetus at birth. Endometrium, the inner mucous membrane lining the uterus. It can be further subdivided into two parts. Deep stratum basalis changes little throughout the menstrual cycle and it is not shed at the menstruation. Superficial stratum functionalis. This proliferates in response to the estrogen and becomes secretory in response to the progesterone. It is shed during the menstruation and regenerates from the cells in the stratum basalis layer. Ligaments. The tone of the pelvic floor provides the primary support for the uterus. Some ligaments provide the further support, securing the uterus in place. They are broad ligament. This is the double layer of the peritoneum attaching the sides of the uterus to the pelvis. It acts as a mesentery for the uterus and contributes to maintaining it in the position. Round ligament, a remnant of the gubernaculum extending from the uterine horns to the labia majora via the inguinal canal. It functions to maintain the anteverted position of the uterus. Varian ligament. This joins the ovaries to the uterus. Cardinal ligament. These are located at the base of the broad ligament. The cardinal ligament extends from the cervix to the lateral pelvic wall. It contains a uterine artery and vein in addition to the providing support to the uterus. Uterosacral ligament. This extends from the cervix to sacrum. It provides support to the uterus. Vascular supply and lymphatics. The blood supply to the uterus is via the uterine artery. Venous drainage is via the plexus in the broad ligament that drains into the uterine veins. Lymphatic drainage of the uterus is via iliac, sacral, aortic and inguinal lymph nodes. There will be a ovarian artery, uterine artery, internal iliac artery and the vaginal arteries. Clinical correlation. Hysterectomy. This is a surgical removal of the uterus, usually as a result of cervical or the uterine cancer. In performing a hysterectomy, a good knowledge of a regional anatomy is needed to prevent accidentally damaging the other structures in the pelvic region. The uterine artery crosses the uterus approximately 1 cm laterally to the internal OS. Care must be taken not to the damage of the uterus during the clamping of the uterine artery during the hysterectomy. The relationship between the two can be remembered using the phrase water under the bridge. Water refers to the ureter and the uterine artery is a bridge. Innervation. Sympathetic nerve fibers of the uterus arise from the ureterovaginal plexus. This largely comprises the anterior and intermediate parts of the inferior hypogastric plexus. Parasympathetic fibers of the uterus are derived from the pelvic splenic nerves S2 to S4. The cervix is largely innervated by the inferior nerve fibers of the uterovaginal plexus. The afferent fibers mostly ascend through the inferior hypogastric plexus to enter the spinal cord via T10 to T12 and L1 nerve fibers. Clinical correlation. This disorders of the endometriosis. This is the presence of ectopic endometrial tissue at sites outside the uterus, most commonly the ovaries and the ligaments of the uterus. The ectopic tissue is still responsive to the estrogenic stimuli, therefore the cyclic proliferation and the bleeding occurs, often forming a cyst. The condition is associated with the dysmenorrhea and or the infertility. Fibroids. They are the benign tumors of the myometrium which affect the 20% of the menopausal women. They are estrogen dependent, enlarging during the pregnancy with the use of the contraceptive pill but regressing after the menopause. Most fibroids are the asymptomatic, but if large enough, the uterine mass can cause the symptoms including the menorrhagia, pelvic pain and infertility. Endometrial carcinoma. This is the most common malignancy of the female genital tract, most often found during or after the menopause, and it is characterized by the abnormal uterine bleeding. Thank you.